Okay, so exactly. He cracked a joke, and I decided to make it into my grand rounds. Want to talk about sexual health and chronic kidney disease. I have a number of slides, and I want to try my best to get through them. I'm watching my timer here. So 1997, great movie, Austin Powers, Ruby baby. Yeah, let's get into it. Here are my objectives: define sexual dysfunction as an important health-related quality of life and chronic kidney disease. Identify how highly CKD patients prioritize sexual dysfunction as a health-related quality of life compared to other health-related quality of life measures. Identify probable practice patterns among nephrologists with respect to discussing sexual dysfunction in CKD patients. Discuss the etiology and treatment of sexual dysfunction in males with CKD. Discuss the etiology and treatment of sexual dysfunction in females with CKD. I just want to start with a general statement that being sexual is being human. And I found this quote from one of my favorite authors of 20th century American literature. And he writes, "What freedom men and women could have were they not constantly tricked and trapped and enslaved and tortured by their sexuality. The only drawback in that freedom is that without sexuality, one would not be human. One would be a monster." That's John Steinbeck, East of Eden, mid-20th century author. One of my favorite novels. I suggest it if you haven't read it. So I got curious when I was doing the research for this topic, and I was able to find studies going back 50 years that explored this topic, and I found that interesting because it's just been on the minds of nephrologists for so long. And here we are talking about it today. And we'll go through a study in a few minutes where we look at practice patterns of nephrologists on this subject. It really doesn't come up that much. That's my surprised Pikachu. So the KDIGO guidelines were just updated, and I focused on the opening statement by the non-nephrologist patient member of the KDIGO work group. I highlighted some things here that he says. He says the identification of CKD begins a long journey for any patient that will have a direct impact on their lifestyle and future health outcomes. Without a holistic approach to patient care, much of the potential effectiveness of medical interventions can be diluted because of patient circumstances and psychological challenges. As patients, we believe that the best approach is for any physician to aim to achieve a partnership of knowledge with the patient regarding their CKD care. That speaks to this topic. This will build patient confidence and self-awareness with the aim that any patient who sadly arrives at possible dialysis is in the right state of mind, which is critical for a considered approach to the next stage of a patient's journey. So I have a man here, and what I'm illustrating here is that these patients with CKD are often affected by multiple comorbidities. That's his counterpart, the female. He has diabetes. He has vascular disease. She has psychosocial stressors. She has heart disease. She's unhappy. This man, he's unhappy. I took this quote from a anonymous user, CKD patient from an online forum, blurted out something there, but basically she writes, "CKD blank out loud, no question. It's especially bad when you have multiple contributing factors." Health-related quality of life in CKD. We're talking about pain, sleep disorders, restless leg syndrome, uremic pruritus, depression, poor appetite and anorexia, nausea and vomiting. Representative there. The list goes on. So let's get into some studies. Patient-reported health-related quality of life and severity scores across CKD populations. If you've gotten into the new KDIGO guidelines, you'd be familiar with this figure from section 5. So what it represents here is that there was a 2022 systematic review referenced in the guidelines regarding patient-reported health-related quality of life factors and the severity scores attributed to each factor. This study had two aims. Number one, provide a global synthesis of health-related quality of life burden across all CKD stages, and then explore which symptom or domains are modified by CKD and may be attributed to this disease. So, what they may mention here is that oftentimes patients identify these health-related quality of life measures as more important than clinical outcomes, such as survival. They looked at 126 patient-reported studies involving people with chronic kidney disease stages G1 through G5, not on kidney replacement therapy, and that's what's represented here. And they identified the most common symptoms experienced in terms of prevalence and severity in this population. You'll see that the most prevalent symptom was fatigue up there in the top left. But what I wanted to demonstrate was that sexual dysfunction actually had the highest severity score circled there by far. And that really surprised me. So this review also looked at populations receiving dialysis and or transplantation, allowing for comparison of prevalence and severity scores across populations. And this kind of provides insight into the symptoms that may be attributed to changing or deteriorating kidney function, and then improvement after transplantation. And I circled here, this is the row for sexual dysfunction. High severity score, again, in the non-renal replacement therapy population. High severity score in the dialysis population. And then interestingly enough, a high severity score in the transplant population. However, a reduction in the prevalence compared to the other two.
And it is from 1 to 100 or
The severity score? That was 1 to 100. Yep, 1 to 100 scale.
Do you know if there is any age match control to compare? Like, I don't know what age and its prevalence, but compared to what? Is that bad?
Age match control for this large study, I don't recall off the top of my head. Another thing we get into here, and this is difficult when we study sexual dysfunction in the population, is that it's particularly hard to define. You can define it by an ICD-10 code. You can define it by the DSM. This is kind of how the DSM-5 frames it as a heterogeneous group of disorders that are typically characterized by a clinically significant disturbance in a person's ability to respond sexually or to experience pleasure. It includes disorders of physical function, and it also includes disorders of interest, arousal, orgasm, etc. Very, very broad, and it makes the entire subject just very difficult to study. So, what are people saying about it, right? What are patients saying about it? We often start these grand rounds with a kind of a case vignette. And I didn't have that. And I didn't foresee that I'd ever have that. So I went online, went to the kidney disease subreddit, and I searched for sexual dysfunction, and I pulled out some candid quotes, what people were saying. And what struck me about this is I had never heard these complaints in 2 years of fellowship. And it just strikes me that often people seem to be more comfortable sharing with anonymous people online their problems with sexual dysfunction and kidney disease than with their nephrologist. And it's all over the spectrum, right? I'm stage 4 and I have no desire. It sucks. I'm a 33-year-old female. I'm married. I'm currently on PD, waiting for my second kidney. My sex drive definitely went down as my kidney function did. There are very rare occasions I want to do anything more than a peck on the lips. I know it's hard for my husband, marital discord, but I know things will change back to normal once I get a kid. That's what people are saying. So how are we as nephrologists doing in discussing these things? Given that there's a growing body of evidence that sexual dysfunction diminishes patients' health on several levels, few studies have been performed to examine to what extent the nephrology community discusses these issues. Discussing sexual dysfunction with CKD patients, practice patterns, and the office of the nephrologist is the title of this study. And this study determined to what extent the nephrologists discuss sexual dysfunction with their CKD patients and the barriers involved to that discussion. So the researchers gave a 50-item questionnaire sent to practicing nephrologists across the Netherlands to reveal current practices and barriers regarding discussing sexuality and fertility issues. Information was obtained about the current level of knowledge of the nephrologist, the need for training and accountability for bringing up sexual dysfunction. Here's just a few questions from the questionnaire. I included on a few. How often do you, I can't even read it. How often do you discuss sexual dysfunction with a new patient, right? I circled this one. How many of your patients with chronic kidney failure, not yet receiving renal replacement therapy, experience the following sexual complaints? And I circled it because they didn't have a column for I have no idea, which is what I would have answered. Right? That's my critique of the thing. So discussing sexual dysfunction, what are the results? 57.4% stated never, almost never discussed. 1.8% responded more than half the cases. Reasons for not discussing. Number one, patients do not express sexual dysfunction spontaneously. Right? Never once in 2 years of fellowship has this come up really in a patient discussion. So when sexual dysfunction is discussed, most common subjects in male patients are, number one, erectile dysfunction, decreased libido, number two, and side effects of medication, number three. In female patients, decreased libido, pain during intercourse, and side effects of medication. Our knowledge, more than half of respondents stated to have some knowledge necessary to discuss issues concerning sexual function with patients. Only 2.7% stated they have a lot. A majority of nephrologists stated that insufficient attention was paid to sexual dysfunction, as well as treatment options during their training. So that's one reason why I did this talk.
What was the percent of responders to this survey?
Let me see if I have that in my notes. Obviously, they do make mention of it in the results section. I can't recall, the survey was sent to about a little under 400 practicing nephrologists. That's what I remember.
And the amount of responses? About 100, right?
About, yeah. Moving on. General contributors to sexual dysfunction in the CKD population, starting general and then getting more specific. Anemia, cardiovascular disease, chronic kidney disease, mineral and bone disorders, sex hormone disturbances, autonomic neuropathy, hyperprolactinemia, medication side effect, comorbid illness, psychosocial factors, the uremic milieu, and chronic pain. So now we're going to shift gears and start to talk specifically about men, and we will focus in on erectile dysfunction because it's the most common manifestation of sexual dysfunction in men.
So I was just wondering, did you come across any study which correlated SD to SPQL or KDQL?
I'm sorry, what's the question?
Did any study correlated the severity and prevalence of sexual dysfunction, kidney disease, quality of life?
You're talking correlation between the degree of kidney dysfunction?
And the quality of life measures
Oh, by stage.
by the dysfunction.
I did this much. I can't recall specifically. Yeah.
The reason being, I think, if your quality of life measures don't capture a variable, then does two things. One, the awareness would be much lower. And two, whether your measure for quality of life, which is supposed to be an all-encompassing measure, whether that's truly a measure that your patients care. But nowadays, there is a lot of debate going on between patient-reported outcome measures and what measures are truly reflecting patients' wishes. And I think the KDQOL has, for all its complexity, there is a bunch of things there where you are uncertain as to what the real value of those are. And
Sexual assault prevention.
yeah, there is one, I think, and I don't know what the verbatim is, but there is like a tangential mention. I think it's a tangential mention.
Yeah, a little bit later in the talk, I do discuss a survey has been used in females with chronic kidney disease that specifically asked about their sexual related quality of life. It's been used in a few studies. In men, erectile dysfunction is the most common manifestation of sexual dysfunction. It can lead to depression, low self-esteem, and marital discord. A prevalent 71% of males with an eGFR of less than 60. Prevalence between 68 and 92% among men on dialysis. Prevalence is similar between HD and the peritoneal dialysis population. We had a 2012 single worldwide cross-sectional study published of 946 patients on hemodialysis. 83% had ED, 47% considered it severe, and interestingly, only 4% were on pharmacologic treatment. And I cited all these studies that I used. They're all accurate. They're in the end of the presentation. So the pathogenesis of erectile dysfunction in uremic men includes disturbances in the vascular system, disturbances in the neurological system, disturbances in the endocrine system, psychological factors, and then other factors like medications, anemia, and secondary hyperparathyroidism. That is the male penis. So normal erections, they require blood flow from the hypogastric arterial system and the specialized erectile chambers of the corpus cavernosum and corpus spongiosum. You have occlusive disease of the cavernosum artery, that's pictured here. You can have occlusive disease of the pudendal artery, that's pictured here, and proximal iliac arteries. There's also pelvic steel syndrome. This syndrome results from blood being diverted from the corpus cavernosum in order to meet the oxygen requirements of the other parts of the pelvis. And then regarding veno-occlusive dysfunction, such abnormalities lead to venous leakage and therefore inability to achieve and maintain an erection. Now switching gears to endocrine factors involved in sexual dysfunction in uremic men. There's reduced gonadal function. We'll go through that in a lot of detail. Decreased production of testosterone, reduced hypothalamic pituitary function. So blunted increase in serum LH levels, luteinizing hormone, decreased amplitude of luteinizing hormone secretory burst, variable increase in serum FSH, follicle stimulating hormone levels, and increased prolactin levels. And here it is. Spent a lot of time on that. So the overview of normal HPG axis and function in men. We'll go through this. So in men, all right, here we go. Pulsatile secretion of gonadotropin releasing hormone stimulates pulsatile release of follicle stimulating hormone and luteinizing hormone from the pituitary. These gonadotropins, in turn, induce testicular production of the steroid hormones, testosterone. This has both positive and negative effects on release of gonadotropin releasing hormone from the hypothalamus. So in men, FSH, in association with high levels of intratesticular testosterone, promotes spermatogenesis. And luteinizing hormone stimulates the Leydig cells' testosterone production. Luteinizing hormone, therefore, is the primary regulator of testosterone secretion. Testosterone is the primary regulator of gonadotropin secretion in men in turn. We're going to come back to this. So effects of chronic kidney disease, end-stage kidney disease on this axis. In general, you have impaired spermatogenesis. There is testicular damage. There is reduced free and total serum testosterone. There is disruption of gonadotropin release. And then finally, there's elevated prolactin due to both increased production and reduced clearance. So let's go back to it. What we'll do is we'll focus on all those parts of dysfunction, kind of starting at different parts of the axis. Spermatogenesis, this part here. So, CKD is associated with impaired spermatogenesis and testicular damage, often leading to infertility. There's decreased volume of ejaculate, either low or complete nasospermia, and a low percentage of motility. So these abnormalities are often apparent prior to the need for dialysis and then deteriorate further once dialytic therapy is initiated. Histologic changes in the testes show evidence of decreased spermatogenic activity, with the greatest changes in the hormonal and independent later stages of spermatogenesis. Other findings include damage to the seminiferous tubules, interstitial fibrosis, and calcifications. As the time on maintenance dialysis becomes prolonged, interstitial fibrosis and calcification also develop in the epididymis and corpus cavernosum. Now looking at the sex steroids in men specifically. So the testes also show evidence of impaired endocrine function in addition to impaired spermatogenesis. Total free and total testosterone levels are typically reduced, although the binding capacity and concentration of sex hormone binding globulin is normal. Low free testosterone is first detected with only moderate reductions in the GFR and before basal levels of testosterone fall as CKD progresses. And now the core of the axis. So number one, in chronic kidney disease, there's lack of cyclic pulsatile release of both gonadotropin releasing hormone and pituitary luteinizing hormone and FSH. This has been demonstrated in some models of uremia. And the amount of luteinizing hormone released per secretory burst is reduced. So the pattern of release is critical in normal function for gonadotropin cells and reproductive capability. Alterations in the pulsatile release of gonadotropin releasing hormone, this leads to the hypogonadal state. Kind of despite the changes in frequency and amplitude of these bursts, kind of paradoxically, the total amount of luteinizing hormone is elevated in the plasma of patients with chronic kidney disease. And then excess luteinizing hormone is thought to result from the diminished release of testosterone from the Leydig cells, because testosterone normally provides a feedback inhibition for luteinizing hormone release. And then finally, I have hyperprolactinemia up here. It's well known that serum levels of prolactin are elevated in the CKD and end-stage kidney disease population. Really due to increased production of prolactin and then reduced renal clearance of prolactin, which is also thought to cause alterations in the pulsatile nature of gonadotropin releasing hormone from the hypothalamus. This is just a general schematic that one can use from Dr. Palmer on the evaluation of sexual dysfunction in the male with chronic kidney disease. And you kind of you do history and physical exam, optimize dialysis delivery, treat anemia, treat hyperparathyroidism, review the medication profile. All that is number one. And then we look at libido and erectile dysfunction, and we kind of work from there. Mention that. Ensure anemia is treated as a goal, as there is associated improvement in well-being with the correction of anemia. Erythropoietin therapy has been reported to cause normalization of the pituitary gonadal feedback mechanism and reduction in plasma concentrations of luteinizing hormone, FSH, prolactin, and increase in testosterone levels. These are my cited studies. They'll be at the end. And control secondary hyperparathyroidism. Number one, this can help reduce arterial wall calcification. Number two, 125 hydroxyvitamin D may be of benefit and lowering prolactin levels. And improving sexual function in some patients. Maybe improve that pulsatile release of gonadotropin release.
Do you know the mechanism by which chemotherapy produce LH at this stage? Prolactin? Is it just normalization of the hemoglobin, or is it a direct effect?
I'm not sure. Not sure, but what I did get into, I'll talk about it a little bit. History and physical exam. So normal erectile function prior to the development of chronic kidney disease points to a secondary cause. Signs of neuropathy, including neurogenic bladder, suggestive of a neurologic etiology of erectile dysfunction. Signs of peripheral vascular disease indicates reduced penile blood flow. Presence of secondary sexual characteristics should be assessed. The lack of these findings may suggest primary or secondary hypogonadism. Review medications, specifically for sexually acting agents and beta blockers. And then the absence of nocturnal or morning erection would make an organic cause more likely. Our vascular and neurologic evaluation of impotence. Vascular studies. One can do an ultrasound of the penis for measurement of penile blood flow, penile pulse pressure, and penile pulse palpation. Regarding neurologic impotence, it is highly suggested by confirmation of the presence of a neurogenic bladder. And these tests, right, we don't do them often. They're usually reserved for non-responders to a therapeutic trial of sildenafil, and who would also be surgical candidates for a penile prosthesis. Okay. Reference below there. Okay. So many physicians now utilize sildenafil as a first-line therapy for patients with vascular, neurologic, or psychogenic causes of impotence, right, outside the chronic kidney disease population. So sildenafil is efficacious on patients on either HD or PD, and vardenafil, which one it is, has been shown to be efficacious in HD patients. And that's the study I cited there, all the way back to 2001. But remember, sildenafil remains contraindicated in patients who are taking organic nitrates, and also exercise caution in patients with coronary artery disease. Okay. So the endocrine evaluation, if you remember my flow chart, now we're down here. So decreased libido, normal erectile function. One can check the serum testosterone and prolactin levels. The level of prolactin is high, usually in consultation with an endocrinologist. A trial of bromocriptine with them can be utilized. More commonly, the prolactin level is closer to normal, and the testosterone level is low. The trial of testosterone therapy is perfectly fine. However, testosterone therapy may not restore libido in uremic minute. So this citation here, number 10, that was a report of just a report of 27 male dialysis patients with biochemically proven hypogonadism. And they were given depot administration of testosterone and full sexual restoration of their sexual function was only seen at 3 of those 27 patients. But despite these findings, in a hypogonadal patient whose primary complaint is decreased libido, a trial of testosterone may be warranted for other reasons. Improvement in bone mineral density. Androgens are known to play a significant role in bone metabolism. And in the non-uremic men, they can often be used to improve bone density during the aging process. So the next logical step would be to use them in the uremic. Improved protein calorie malnutrition. And then improvement in anemia. Especially, and I found this really interesting, living in the post ESA era, because I learned that especially before the availability of erythropoietin, transfusions of androgen therapy were the blood transfusions and androgen therapy were the viable treatment options for anemia in dialysis patients. And I found the New England Journal, I didn't put it in here, but I found the New England Journal article from 1981 that was studying the optimum testosterone to use for anemia in the dialysis population. So that's just my chart again.
Can I ask a question for the previous slide?
Thanks.
So why don't we routinely prescribe testosterone with low testosterone level in CKD patient? Do you think that would be any harm? I see all the benefits. About those versus cons.
Well, I think that the cons of testosterone therapy in the CKD population would be similar to the cons of testosterone therapy in a non-CKD population. Higher blood pressure, higher, I think higher risk of stroke, blood clot. So yeah, absolutely, there's risk. And you would want to monitor them in the same way you would do in the non-uremic population with testosterone levels, CBCs.
But in the urology community, like, low testosterone levels aren't really in place, so it's a problem.
They're not
Right.
replaced unless they're a problem.
Unless there's like some things. I'm not aware of like any sort of just like get every man's testosterone. Like,
Yeah.
Right?
The range is so actually like that's wide that it is difficult to find an absolute.
Right.
Yes.
So you find it low for the symptom, so you should have something that would can have.
I mean, the question is, are you going to hang your hat on the symptom being low libido, anemia, and I know a patient that has a GFR of 30 and their testosterone is low. Right. And again, I've optimized everything here.
Right, and I think what comes up with the used to come up with the VA is the primary here is the indication of testosterone. Right, most men, if they do have complaint, it's erectile dysfunction, not low libido. And testosterone does not help with that, right? It helps with libido, but it's not erectile dysfunction.
Yeah.
So those are very different definitions.
Yes,
Very clear expectations, right?
does not help with erectile dysfunction, and that's why I have here normal erectile function as a prerequisite for the party pathway that I adapted from Dr. Porter.
Right, exactly. And I think once you explain to the patient, it changes the therapeutics, right? Switching to medical development, the range of medications there versus addressing other issues.
Okay, finally, all right, there's a lot, men are far more studied, and I fell into the trap when I started with men, when I started with erectile dysfunction. Right, here we go, sexual dysfunction in the female with chronic kidney disease. I made this chart because I really had a hard time wrapping my mind around how I wanted to express this, so this is how I did it. Most studies published on the topic of sexual dysfunction and kidney disease focus on men rather than women. It's likely due to perceived difficulty in the assessment, and more complex pathophysiology, as women can experience a range of symptoms spanning from lack of interest to menstrual and fertility issues. So what I did to represent that complexity, I came up with this diagram. This is how I'm just seeing it in my mind. Because I want to try to stay focused on how the patient perceives her own sexual function. That's why at the top circle is effects of CKD on the patient's desire and satisfaction. So on desire and satisfaction as experienced by the patient as at the top. Beneath that, I've chosen to include the effects of CKD on the hypothalamic pituitary ovarian axis, as dysregulation of the axis is the underpin of many of the other manifestations, including the patient's unperceived satisfaction up at the top, menstrual and fertility considerations to the left, and then vaginal complications to the right. All within the box of sexual dysfunction. So we talked about this a little bit, objectively measuring the effects of CKD on desire in women. Okay. So the degree of sexual dysfunction in women, it can be used by something called the FSFI. That's the Female Sexual Functioning Index. It is a 19-item questionnaire developed back in 2000 and evaluates 6 domains of sexual function: desire, lubrication, arousal, orgasm, pain, and satisfaction. So each domain has a maximum score of 6, with a higher score correlating to better sexual function. And the sum of all domains is calculated for a maximum score of 36. Why do I bring this up? Well, it's because in the few studies that have been published that objectively measure sexual dysfunction in women from a patient's perspective, this one was used as the FSFI. There's this study here, assessment of female sexual function and quality of life in pre-dialysis, peritoneal dialysis, HD, and renal transplant recipients. And they said 81% of women with CKD did have a significantly lower FSFI score than the control group, so the non-CKD group, with that score being 13 versus 24.
Was there different therapies on groups to transplant people that didn't get better?
It's kind of different studies say different things. The general expert consensus is that sexual dysfunction, the prevalence of sexual dysfunction certainly goes down after transplantation. The only conflict that I found with that was in that large study that Indigo mentioned, where although the prevalence went down, the severity score, the patient's perceived severity score, sexual dysfunction after transplantation went up. And that surprised me. I don't know why I didn't read into it. I can conjecture that maybe it had to do with the patient's expectations changing prior to transplant. Like they think they're going to be all perfect and they're not, or something like that. It's just complete conjecture.
That was men and women.
That was in men and women both. Yeah. Yeah. Mm-hmm.
So, like you said that, maybe there could be other causes of sexual dysfunction in men and women because of comorbidities that are associated with CKD and with transplant.
Those comorbidities, they're still there.
Yeah, the diabetes
Yeah,
or
still there.
disease is what. Diabetes maybe getting blood sugar cut with higher up, but for the vascular occlusion, the dysfunction.
We'll go back to the axis in a second, but the general effects of CKD and its kidney disease on the hypothalamic pituitary ovarian axis function. So in premenopausal women, they can experience anovulatory cycles. So there's pre-ovulatory estradiol and luteinizing hormone peaks are absent, so we lose that cyclicity. FSH and LH levels again are high or normal during the follicular phase, but again, they lack that cyclic nature as well. estrogen levels are low or normal for follicular phase, and then progesterone levels are very low. Experience dysfunctional uterine bleeding. And then you have to separate the menopausal women. Interestingly enough, the effects are less so. So they still have an appropriate elevation of FSH and LH, and then appropriately low estradiol, that's menopausal. Both populations, they have elevated prolactin due to reduced production and reduced renal clearance. So the normal HPG axis function in the female. Starting with the hypothalamus, gonadotropin releasing hormone is secreted, causing pulsatile release of FSH and luteinizing hormone from the pituitary gland. Both FSH and LH aid in ovulation and the synthesis of ovarian sex hormones estradiol and progesterone. Progesterone provides negative feedback to the hypothalamus, so negative feedback on gonadotropin releasing hormone, and the anterior pituitary, FSH and LH. That's that line there, negative feedback. Estradiol provides negative feedback to the hypothalamus as well, but only negative feedback to the pituitary with respect to FSH. High estradiol levels are required for that surge of luteinizing hormone to cause the ovulation. And then post-ovulation, progesterone is secreted from the corpus luteum to prepare the endometrium for implantation. So in the CKD population, we have the loss of the pulsatile gonadotropin releasing hormone release. That's thought to be due to GnRH inhibition from hypoprolactinemia. This loss of cyclic GnRH from the hypothalamus impairs the pulsatile release of FSH and LH from the pituitary, so that the rate of release is more continuous. So there's an overall increase in luteinizing hormone levels. There is an overall reduction in estradiol levels. And as a result of low estradiol, there is reduction in positive feedback on luteinizing hormone release. So there is no luteinizing hormone surge for ovulation. And with no ovulation, progesterone fails to rise. And then in the background, without progesterone rise, the endometrium experiences a low level of unopposed estradiol activity on a kind of on a 24/7, 365 basis. Circled in here. I like this. I pulled this from this study that's just showing the usual cyclical phase, and then a representation of the relatively high luteinizing hormone levels in kidney disease, and we've just completely lost the cyclic nature. No rise in estradiol, no luteinizing hormone surge, reduced chance of ovulation.
And is there any study that shows the transplant will reverse this pattern?
Oh, yeah.
Any objective,
Oh, objective studies?
like levels of hormones and axis can be
Oh.
established?
Yeah, there are, but I read some. I can't recall them off the top of my head.
So there was
Yeah,
reversal,
there have been studies. I can find it for you.
but there was a reversal in your knowledge?
Yes, there is a reversal. Yeah, this cycle returns, and they have studied that.
Fertility comes back, right?
Fertility comes back. Mhm. 1 minute.
And then for the previous slide,
Mhm.
what age group is?
Oh, premenopausal.
Well, yeah, of course, but it's 20s, 30s, 40s. All comers.
All comers. That's just me saying that. I was just operating under that assumption. General clinical manifestations of sexual dysfunction in women. etc. Hyperprolactinemia can cause galactorrhea. Loss of libido, hypoactive sexual desire disorder, difficulty with arousal, difficulty with orgasm, vaginal dryness, dyspareunia. And then with menstruation and fertility, we've hit on this, amenorrhea or irregularity, early menopause, infertility, etc. Okay, so treatment of sexual dysfunction in female with CKD. So address sexual concerns, number one, while managing other conditions that can contribute. Depression, similar to the man, anemia, hyperparathyroidism, assessment of medications that may affect sex hormones, optimize dialysis adequacy to minimize uremia and downstream effects of dysfunction. So a few points on the specifics. Hyperparathyroidism, I thought this was interesting, my number 15 reference. Calcitriol has independently been shown to lower prolactin levels, which could potentially improve sexual function. Treat anemia, it's been shown to independently lower levels of prolactin. I don't know the mechanism there. FSH, LH, and increase testosterone levels. It's been independently shown to improve quality of life and sexual function and end-stage kidney disease patients. I'll show you my references at the end.
So number 15, has that been shown to improve sexual function or theoretically, because it can lower prolactin levels, it can?
Oh, that is theoretical. Yeah, that's theoretical. Topical estrogen is perfectly appropriate. And then this is important too. I can't stress this for regular gynecological care. Restoration of the menstrual cycle can be achieved with periodic progesterone treatment, mitigating the hypothesized unopposed effect of low levels of estradiol without the cyclicity of progesterone on the endometrium. Okay. And I was thinking to myself these past few days, when these patients go on dialysis, they usually maintain a primary care doctor, but they don't always. We kind of fall into that trap, and we forget. I would conjecture about if they don't have a PCP, who's doing the pap smear, things like that. Are they seeing a gynecologist once a year or on an as-needed basis? Just my own thoughts. And then counsel on the risk of pregnancy. Patients with CKD who become pregnant risk worsening EGFR, proteinuria, and hypertension. And then pregnancy in patients with end-stage kidney disease is rare, but it's associated with higher fetal risk, complications, and worse outcomes. So if your patient does have an ongoing cycle, birth control is still a discussion that should be had. And finally, a few minutes left, renal transplant and sexual dysfunction. There's just general improvement in sexual desire and satisfaction. 40 to 78% of male patients with renal transplant report a sense of improvement on global sexual function. 25 to 30% of female patients of reproductive age with renal transplant report improvement in sexual performance. Restoration of the normal secretory pattern of gonadotropin release hormone and LH. Restoration in the hypothalamic pituitary ovarian axis can be seen as early as 4 months after transplant. Restoration of normal serum prolactin levels, and then reversal of abnormalities in ovulation and improved fertility. So that's why I decided to stop my talk there, go back to the objectives. Wanted to define sexual dysfunction as an important health-related quality of life in chronic kidney disease. Identify how highly CKD patients prioritize sexual dysfunction as a quality of life measure compared to other quality of life measures. Identify probable practice pattern among nephrologists with respect to discussing sexual dysfunction in the CKD population. Discuss the etiology and treatments available of sexual dysfunction in men. And discuss the etiology and treatments available of sexual dysfunction in females. Well,